Hi everyone, welcome back to the TinyDocs Talk podcast series, Pediatric Interview Edition, your source for the clinical thinking station or clinical reasoning station of the Pediatric Training Interview in the UK. This is brought to you by the British Sudanese Association of Pediatric and Child Health, or BSAPCH in short. I'm your host, Isra Ibrahim, and today we have our presenter, Guiria Ibrahim. She will present a real life demonstration case of clinical thinking station. So, without further ado, let's dive into our episode.
This is your clinical reasoning station. You are informed by the AMS that they are bringing a 3 years old who is having a background of respiratory tract infection, and now he is working hard and is having stridor at rest. So it looks I'm dealing with a 3 years old child who is in severe respiratory distress and stridor at rest. Most likely this is patient of upper airway obstruction. Most likely I have a differential diagnosis if this patient just having stridor and upper respiratory tract, no evidence of toxic appearance or drooling. So my differential maybe most likely this patient is having croup, or I will consider other differential like epiglottitis, bacterial tracheitis, and foreign body. So I will activate the emergency response system, and I will involve my senior immediately, and I will delegate the role to my teams. Then I have to manage this patient in the resus room. Immediately I will push this patient to the resus room. I try as I can to keep this patient calm, and I will manage him on his mother's lap. Then I will connect him to the monitor, and I will apply 100% oxygen by non-rebreathing mask, and will uh, approach this child by an ABCD approach. Regarding the airway, I have to make sure that there is an patent airway. If there is any doubt about the airway or there is partial obstruction, I have to open by the airway maneuver like head tilt and chin lift, and I will keep him on his mother's lap, and I will continue to monitor this patient. Then I will go to the breathing. I will assess his breathing, respiratory rate, respiratory effort. I will see if there is any sign of respiratory distress and recession. I will hear his air entry or there is any added sound. Most likely this patient having stridor at rest. My top differential is Croup, so I will start to give this patient, if he is tolerating orally, I have to give him an oral dexamethasone 150 microgram per kg. If he is not tolerating orally or breast level of consciousness, I have to give him a nebulized budesonide. Then I will move to the circulation. I will not insert any IV line because I didn't want to upset this patient. I will check his airway, his peripheral and central pulses, about his heart rate, capillary fill time, and color. Then I have to apply an adrenaline nebulizer for this patient to buy the time. Then I will move to the T. I will assess his level of consciousness by Glasgow Coma scale. I will examine his pupils, and also I will check his blood glucose. And I will move to the E. I have to make sure there is no rash, and about his temperature, if there is any fever. I have to give him an antibiotic either by orally if he is tolerating, or by rectal. So according to the severity of Croup, I will ask one of my team to print the protocol of Croup, and if there is according to the severity, we will manage this patient. If this patient is severe respiratory distress and there is doubt about his airway, I have to contact the anesthetist and ENT surgeon early. Then I will update the family about the condition of their child and to by every step in the management, and I have to take detailed and focus history by sample. I will ask about symptom and sign, if there is any recent history or cough, shortness of breath, if there is any irritability or toxic appearance, drooling, because I have to rule out other differential diagnosis like epiglottitis and bacterial tracheitis, or this about the event, is it happened suddenly, because I want also to rule out the foreign body aspiration. Then I will ask about his past medical history, any significant past medical history, like any previous or prematurity, long admission to NICU, to also rule out subglottic stenosis. Also to ask about medication, any history of recent medication use, any allergies to anything. Then I have to ask also about last meal and event. Then I will do and proper examination from head to toe. Then if this patient is still in respiratory, severe in respiratory distress, need monitoring, may I have admit this patient to the PICU. I will contact the PICU. If I will be in a district general hospital, I have to inform the retrieval team for transfer this patient to the PICU. Then if this patient is going, I have to monitor him at least 4 hours, admit him for 4 hours. Maybe I will consider to discharge him on another dose of dexamethasone, and I will give the patient the leaflet of the Croup, and I will inform them about the red flag of the, if he develop any severe respiratory distress, cyanosis, drooling, disturbed level of consciousness. For sure, this is should be returned back immediately to the ED. After that, I have to do and debriefing session to my teams to assess our performance, what it does, what done right and what done wrong, so we can avoid in other cases.
As we wrap up today's episode, me and Bisab CH would like to extend our thanks to our presenter, Guiria Ibrahim. Thank you for sharing your insights with us. We hope this episode has provided simulation-like guidance for the clinical thinking station in pediatric training interview. Remember, our journey does not end here. Be sure to check out the rest of our podcast, our YouTube channel, our website for more information. Your feedback is valuable. We invite you to reach out and share your thoughts, question, or suggestion. Together, we can continue to improve and provide content that meets your need. Thank you for tuning in, and until the next time, stay curious and keep learning.